Okay, good afternoon, everyone. Hopefully you can see and hear me okay. Just check. There we go. Hello. Sorry, the wonders of technology nowadays. So good afternoon, everyone. My name is Matthew Pomeroy. I'm a Deputy Director in the National Integrated Urgent Emergency Care Team, and it's my pleasure to welcome you all today to the kick-off session of the UEC Champions, which is part of our Urgent Emergency Care Recovery Delivery Plan offer. So a couple of brief bits of housekeeping from myself before I go and introduce you to today's speakers. And firstly, the session is being recorded for everyone, so if you want to come back and revisit something, it's being transcribed as well for accessibility, and we'll share the recording link to everyone afterwards. Secondly, please do give us your questions and we'll aim to answer those as we go through. So Sarah Jane and Julian will answer some questions, as will our other speakers, as we go through the day. And I just wanted to do a little bit about who we are as an integrated urgent emergency care team. So we're the national team that span the whole of the UEC pathway, from 111, ambulances, hospitals, discharge, our intermediate care and better care fund colleagues, and we're responsible for the kind of strategy, policy, transformation, and we couldn't do that without our colleagues in the emergency care improvement support team who wrap around us and overarch, providing you some on-the-ground support and improvement, and we're doing this in collaboration with them. So enough about that. Today's speakers, I can see some of my colleagues in the background, ignore me. We've got Sarah Jane Marsh, who's the National Director for Urgent Emergency Care and our Deputy Chief Operating Officer. She's joined by Dr. Julian Redhead, who's the National Clinical Director for Urgent Emergency Care. They'll be talking to you today about the UEC recovery plan and what that means in more wider policy context. And then we're joined by Charlotte Aston, who's the National Director of UEC Transformation and Operations, and Helen Bennett, the Head of the Emergency Care Improvement Support Team. And they'll be talking more widely through what it's like, what it's going to be for, can't even get my words out today, apologies. What we'd like you to do as UEC champions, and what that's going to look like for you over the coming months. And Helen's going to talk to us about the improvement offers that are coming up for you all. So I'm going to put my teeth back in and hand over to Sarah Jane to kick us off. Thank you.
Oh, thank you, Matthew, and good afternoon, everybody. Yeah, my name is Sarah Jane Marsh. I'm very proud to be the National Director of Urgent and Emergency Care and Deputy Chief Operating Officer at NHS England, and to be able to open what I think is a really, really important event this afternoon. And I hope you find it really enlightening and it really helps you to understand a little bit more about what you've signed up to with such enthusiasm. So I think my job at the beginning of the session is to talk to you a little bit about what we're trying to achieve with the Urgent and Emergency Care Recovery Plan, and why the work that you're about to embark on is so absolutely critical to the delivery of the things that we know are going to be the most important to our patients and our families, particularly over the winter period. Before I do that, I just want to acknowledge that we're doing this in the context of what is a hugely challenging time for everybody working in the NHS. We're just about to go into a period of yet further industrial action, and that is taking a lot of our time and energy, quite rightly so. In order to keep our patients safe, but it is coming at a cost to the amount of time that we can spend on the transformation of services that we all want to, and it is making many people throughout all different roles and functions, I think, exceptionally tired, and I've meeting more and more people that really are in a huge amount of moral distress with what they're having to face into. So we're really grateful in that context that people have still signed up to do this work and that you're committed and that you're here today, but we do recognise that the situation we're trying to do this in is extraordinary. But we felt it's almost more important than ever to plough ahead, because whatever happens with industrial action, we are going to get into a winter period, and that winter period is going to be challenging. And the more that we can do to get ourselves ready, the more resilient that we can be as a collective team, but coming together to make any improvements that are possible for those that we serve is going to leave us in the best position. And of course, last winter was incredibly difficult. And that's the reason why the UEC recovery plan, which in many ways is this year's winter plan, was actually published in January of this year. And hopefully people will have had an opportunity to read that in depth, or maybe just the highlights of it. But it was really just setting the stall out from the outset that we've got to collectively come together now to do all we can to give ourselves that chance of being able to provide a better quality of service to patients this winter, and obviously along the way making it a more manageable experience for our teams that found it such a difficult period to get through. So I'll just say a few words about the plan itself. As I say, I'm sure it's been out now for many months and I'm sure people have had an opportunity to read it, but just the highlights really. It's framed around two key targets, and these are the ones that you might hear talked about quite a lot in your organisations. They get talked about a lot at boards and in the media and so on. And that is our category 2 ambulance response time. So having an average performance of waiting no longer than 30 minutes for a category 2 ambulance over the course of the year. And then emergency department performance, having a 76% level of performance for patients that are to be seen, treated and discharged from the emergency department within 4 hours. So in some part, you could say, well, it's a plan to deliver those two targets. But of course, we all know that the path to delivering those is exceptionally complex and really takes into account everything that we do across primary and integrated urgent and emergency care. And so if you were going to come up with a subtitle for the UEC recovery plan, I always say it would really be a plan that is about whole system flow. It's about how every part of that system comes together with the best alignment that we can between demand and capacity, and with processes and ways of working that align those things together so it's as seamless as possible for our patients to move through. Now, I've been an NHS manager for well over 20 years now, and that I know that that's a very easy thing to say and an exceptionally difficult thing to do, and therefore all the different parts of actions that make up that do require everybody to come together and lots of different things to happen simultaneously. So just to give you a few highlights in the plan, I think the first thing is let's acknowledge that we do need additional capacity in all parts of our system. We've been through a really difficult few years. COVID has really pushed us all to the edge of what is possible. And we know that we do need more things to make this work, and particularly the people that work in our services that we wouldn't be able to do anything without. So part of this plan is around having more general acute beds, having more ambulance hours on the road to be able to respond to people's needs, having more capacity in our intermediate care and our social care services. And it's a really important building block. If we don't have the right capacity, it makes everything else more difficult. But it also fully acknowledges that capacity building on its own can become part of our problem if we don't do the improvement and the flow work that sit alongside. And that for those of us who work in acute hospitals, you will know very well that maybe you open 20 beds, 30 beds, and that might give some short-term relief. But a few days later, we can be back in the position of having real problems with flow. So yes, we need to build that capacity, and the plan talks about that. For example, 5,000 new general acute beds. But it also talks much more broadly about all of the things that need to come together across a system to make that capacity work. So there's a big element of the plan which is about new models of care in the community, care that can be accessed by patients and families at the time when they need it to keep them well at home. We all know the stories of people dialing 999 and an ambulance comes and provides a great service, but doesn't always have other options available. So therefore we'll take a patient to hospital. They may wait outside for a longer period of time than we would like, go in through the emergency department, wait many hours, and then subsequently be admitted for inpatient care. and at the end of it might not come out with any better medical position than when they went in, and sometimes a deteriorating a social condition and not actually able to go back to their previous life that they were living. So some of this admissions avoidance, it's not just about stopping people coming to hospital, it's about really making sure that the services that our patients and citizens need are available to them when they need it in the community, and that we only send an ambulance and we only take people to hospital if we really, really need to. And there's some great stuff going on around the country on this: the community response, enhanced support to nursing homes, the full services, the virtual wards. But in many places, what we see is that sometimes they work somewhere, but we've got real problems with making that offer consistent. So whenever you need help and support, it can be available to you there in the community. Then we also know that at the other end of the hospital process is that the more effective that we can be around discharge, the more timely we can be in getting people into that short-term care that they need. Again, it's going to reduce our length of stay, it's going to open up our flow, it's going to allow us to pull people out of the emergency department and therefore on the back of ambulances, so our ambulances can go back out on the road. But again, it's about giving patients the services that they need in the community. Now, some of this is about capacity. I think often we tell the story that it's about social care capacity, and of course the numbers tell us that a huge proportion of this is about social care capacity. But it's also about decisions that we make in the NHS. It's about our own rehabilitation services and the way our acute and our community hospitals work together. But it's also around some of our processes. Sometimes there can be capacity available in a community service or in home care services that a patient can go into, but our processes of that transfer of care can make it difficult for the patient to get there in a timely way. And we see that time and time again when we do audits, that many of our patients can just wait for those processes to work through. And then there's also that big element here, which is about how we can navigate through 111 and single point of access, but how we can really navigate our patients, the families, the carers that are accessing our services, and our own teams who often don't understand how the landscape of local services in an area might work around all these services. So we start to get a very different picture of what NHS care and often voluntary sector colleagues can come together to provide for patients and citizens in a local community. So this is a plan about building capacity. This is a plan with a focus on how we do some of that front end delivery and get ourselves into the best shape we can going into winter. But it is also truly transformative in the way that it is thinking about the delivery of urgent and emergency care. Just a few other points I'd like to make about it. We've really tried to think about the way we do this down the eyes of, or through the eyes of, the patients that need our services most. So many of those at the moment that are not getting great experiences, that are having long waits and not necessarily getting the benefits of some of the care that we're providing, are our frail older people that need a lot of care and support and input. But we would all recognise that not always needing to come from our acute hospitals. So that is a thread that runs through all of the different areas in the recovery plan. And that's also true for younger people. We know when we go into difficult winter periods, we get surges in respiratory illness. It's often our younger people and families that can't find their way into the most appropriate appointment for them and therefore need to come into hospital to get support and appointments when we know that we could look after them well in primary care and other settings. There's also a huge element of this which is about urgent and emergency care for people that with mental health conditions that need help and support quickly, some of which are very much managed in the UEC mental health pathway, which is under huge pressure in and of itself, but some of which cross over either because they've got combined health mental and physical health needs, or they end up in our acute hospitals while they're waiting to go to mental health services. So the plan is acknowledging of the actions that need to take place there as well. And we also touch on the differing access that people have to and the way that people use urgent and emergency care, and that often those living in areas of high deprivation will use urgent and emergency care rather than primary and outpatient services often. And some of this is about how we make sure we can more consistently offer a service that meets those people's needs. So it's not a plan about hitting targets. It's not a plan about doing more of the same things more quickly. This is a citizen offer that says to you the way that the NHS works and the way that urgent and emergency care works is changing. If you fall over, if you need our help, it isn't always going to look like a 999 ambulance and a deployment to hospital. It might look very different in the future, and that is good. That's good quality for you as a patient and a family. It's also much better for those that genuinely need the acute services, because there'll be more capacity and flow available and open to those people who most benefit. To do this, taking a performance management approach is not going to work. And I think most people involved in this call and that have chosen to be an UEC champion and on this webinar today are going to be here because you believe in the power of performance improvement. And that is absolutely where we are as a team. There are so many things that you can do with action plans, with charts, with Gantt charts and timescales, and there's a place for them. But if we're really going to think about how we lock these services together, how we make the capacity and demand and the flow work, and we use the assets, the biggest one of which is our people, in the most productive and effective way, we're only going to do that through improvement. And improvement has many elements to it. Some of it is scientific and some of it is absolutely about culture and leadership. And embedded in our programme, we have both of those elements. So we're using the best practice that's available to guide the way we walk people through the improvements that we want to make. But we totally recognise that to do that, we need a leadership community that is working to a common set of goals in a culture that celebrates improvement, allows people to take risk and sometimes get things wrong for the good of what we're trying to do in the medium to longer term. So our commitment as a team is to help and support everybody through the process, and particularly over the next months where we know it's going to be challenging, work together to make genuine improvements that are going to help to keep patients and families safe over winter and are going to help our experiences of working in the NHS. So we're going to be by your side through this journey, and we're here to learn as well. We don't have it all right from the outset, so there'll be lots of things that we need to change and refine along the way, but we are here to bring that improvement approach to the delivery of the UEC recovery plan. Now, the other thing that we believe very strongly in is the power of the managerial and the clinical leadership working together as partners. We can't do all of this through clinical engagement. We need management and leadership input alongside, but at the same time, we are not going to do it unless it's a genuine partnership with our clinical leaders. And on that note, I am delighted to introduce my colleague, Dr. Julian Redhead, who I think is hot-footing it from a range of national media engagement. So apologies, it's a downgrade for you, Dr. Redhead, who is just going to talk a little bit from his perspective around the plan, and then we'll pause and see what questions and comments people have been making in the Q&A box. Over to you, Julian.
Sarah Jane, thank you so much. And I'd sort of start by saying there's almost 300 people on this call, and I think that really illustrates the importance that people attach to the IUC programme and how we improve this for both our patients but also our staff, because I think it's both aspects that we need to be able to do. And that's why I'm really pleased that the plan was built on work that was done with clinicians, with managers, COOs and everybody else, allied health professionals, nurses, to really build up to what the recovery plan was. So these ideas didn't come from sort of Wellington House or the sort of ministers. This came from people from the ground floor and shop floor and really built up into a plan. So I think we have a very good, credible plan. And I'm really pleased that we've now developed these champions, or we will develop these champions, and it'll be your enthusiasm and your insights and your collaboration that you're going to bring to us and really help us to bring this whole programme alive, because we've got to make sure that we've got this in place for winter to really help each other and our patients to have a better care and a better work life as we go through this as well. And I think Sarah Jane alluded to sort of almost three aspects to this. There's the sort of the pre-hospital, if you like, which I would put down as sort of better care pathways, and how do we make sure that patients are on the best care pathway for their condition, and especially where that doesn't mean that they need to come to A&E. Then within the departments, there's better flow, and how we segment patients to make sure they're getting the best care. So that's SDEC, that's making sure that we've got senior advice at the front door, we've got the right investigations going. And then there's the tail end, which we all know is really important, and that's the flow out of the department, which is why we've got the two big targets, but some of the work we've done is really looking at 12 hours total time in department as well as long lengths of stays within the hospital, because it's that flow out and back out into community, back out to the patient's own home, and back out into social care, which are really important. But what I would say is that what we know is that every part of that system is under stress. And there was a report today from the Healthcare Foundation talking about community care and how the pressure is building within community care in terms of patients not being able to be discharged. We know that social care are under pressure. So it's a question of us really understanding those demanding capacity across the system. And that's where all of you with such good varied backgrounds can really help us. I think the other thing to say is that we talk about the two targets, the 4-hour target, and we've got the ambulance target. But I think we've got to consider those targets as system targets. And that really builds into how we look at that across the system, because it's not just the ED, it's not just the hospital. And we can see that through the whole flow out of the hospital, as well as inside and building on primary care. So I think the other side to this, and especially with the Winter Letter, it builds on the work done through the primary care strategy which has come out. It's built on the elective care strategy, because we know that the electives and that interaction with electives and emergency is so important to us as well, but also on the workforce plan. And we've got to start building on that workforce plan about how we go about doing these things. The other part of this, and I think we've all got to keep each other on target with this, which is to make sure we're not just concentrating on the sort of the relatively well or the normal patients who come through A&E. We've got to think about the mental health. We have to think about learning disabilities. We have to think about children and young people within this. And I'm hoping that you as champions will keep us online with that and make sure that we don't lose those aspects. And then I think there's the aspect here of digital and how we use digital into our innovations. And we've seen work around the electronic bed management system. We know that it's really important about how EPRs work. And we know that trusts don't necessarily have all those. And we've tried to make sure that we're building on that digital infrastructure as well, to make sure that we can use those processes to help us. And that builds into virtual wards and hospital at home and virtual care as well, which I think are going to be very important. And the final aspect that I was just going to raise up is inequalities, because we know that one of the biggest part of urgent emergency care is that it's one of the biggest inequalities, because we are, as Sarah Jane alluded to, that the biggest population which comes, or relative population that comes, is in those inequalities. They are those patients who are often hard to reach. I don't really like that term, but you know what I mean. Those patients who we need to get to, and therefore it's really important that we develop these systems with those in mind as well. And I'm really pleased that Bola and other people in the inequality team are working really hard on us around sickle cell and other aspects of high intensity use as well, which are all part of our plan too. So I think that's probably enough from me. I'm really worried here, because unless you start asking lots of questions, Matthew's going to ask me questions, and I know that he's got some devious questions for us. So please, I beg you, start to put some questions into the question and answers, and we'll do our best to answer them. But thanks very much for listening.
Well, Julian, I'm going to creep out the shadows, but you're staying on camera because you're used to that more than me. We do have some questions, but it does almost kind of feel like you've been reading the chat box as you've been presenting, because there's actually some quite common themes that have come through from the questions that have been asked. So there was a comment around how we need to acknowledge that IT isn't compatible across all services and systems, and that makes life so much harder. And I know you touched on that with the electronic capacity bed management systems. I don't know if you wanted to touch on that any further. No, start of 10.
No, Matt, I think this is a really important point. And I think that, I mean, I come from a trust which has got a lot of IT infrastructure, and we invested heavily into IT infrastructure. And we've also started to look at our EPR, and our EPR now is going across 4 different trusts within our ICS. So every single trust with us, which is 8 sites, 4 trusts, will all be on the same EPR. And that means that when patients move through our healthcare system, both between specialist hospitals and more local hospitals, those notes go with them, and it's much, much easier. We can see scans, we can see x-rays. So I absolutely understand the importance around how systems link up. We also need to link in with our GP records, and that needs to be seamless. It can't be that we go through one system and another system, because that takes up a lot of time. What we need is seamless integration so that we can look at those notes across the systems as well. And I'm sure that we'll touch on that a lot with our champions as we go through as well, because that's something you can help with, and help us understand and help us bring those to light about how we can use that technology to help us as well.
Thanks. And just for those that are on the call that might not be fully aware, we've done a digital maturity assessment for all ICSs, and we're starting to prioritise those with the greatest need to start improving some of that digitisation in the IT systems. So hopefully more will follow. So I would just say to everyone, watch this space and talk to your trust colleagues about what's happening there and how you could support that. Another one for you, Julian, and then I'll put Sarah Jane in the firing line. The question was, are there any good examples of systems that are doing really well with admission avoidance, but might just be a good all-rounder for, how are we managing sharing good practice amongst systems? And there was another comment that linked into that, which was, what are your thoughts on sharing some of the good practice without just dragging and dropping from one place to another? So recognising the variability.
So I think this goes to the sort of heart of what we want to do in terms of bringing that collaborative leadership, where we look around, we understand what different systems, different trusts, different communities are doing to support each other, and then being not sort of lifting and shifting, but adapting. Adopt and adapt, I think, is the terminology which comes out of this as well. So this isn't just a question of just saying, well, they do it. We make sure that we learn the principles of what they're doing and then adapt it into our own systems as well. And there are lots of examples of where systems are looking the sort of out of hospital environment to do that. So there are good examples around how the urgent community response is working. There are good examples of hospital at home. There's good examples of how SDEC really works and then links back into community. There's really good examples of frailty around virtual wards or hospital at home as well. So there are lots and lots of examples. And I think what we are trying to do is to bring those to light, being able to take the principle, what people do is to take those principles and ask how can they adopt those into their own systems as well.
Thanks, Julian. Sarah Jane, I don't know whether you're going to pop up on screen or it will stay with Julian, but we've been asked, from the recovery plan, which elements are your must-haves and which are your nice-to-haves? I think it's a really interesting question.
Yeah, so it is, and I think some of this is about the way people go about prioritisation, because there are some things in there. I think I said use the word citizen offer, and I think we firmly believe that they are citizen offers, and we know that some people could achieve targets and standards by doing some of the more traditional models more quickly, but that isn't actually going to serve some of the people that need a very different kind of service in the community with social care, and so on. So we thought carefully about everything that went into the plan. So there's definitely, it sits together as a whole package. In terms of the prioritisation, I think there's a couple of things. The first is, I don't want to get too technical, but as part of the planning round this year, ICBs with trust colleagues will have put together a plan for how much extra capacity is going to be invested in different parts of the pathway, whether that's more beds, intermediate care services in conjunction with the Better Care Fund and so on. I think our first ask is that the things that we've committed to, we do deliver on. But I think the second part of that then is hopefully the answers to that question will be informed by the process that we've just been through to get ready for this event, part of the programme that we're launching today, which is we really want people to hold a mirror up to where they truly are. Because we know often in planning, you know, it's numbers and it's waterfall charts and things. But when you look at those maturity assessments that we ask people to go through, it really gives you, I think, an opportunity to say, actually, we are pretty much, you know, where other people are here, or maybe we're a little bit ahead. But it also allows you to stand back and go, actually, on balance, we are a bit behind here. There are more things that we could be doing in this particular area. So when we've ticked off the things we've already signed up to, I would absolutely say that the prioritisation is what you have decided is the priority when you've completed the maturity matrix and selected your improvement modules. And I think our sort of ask as we go into this is that we don't keep broadening the scope and we don't keep adding things on. We do the few things that you've signed up to do really well, and we prove to ourselves what we all know, but I think there are some skeptics out there. What we all know is that improvement does work, but it's not a silver bullet. It takes hard work, and we have to work through it methodically as a complete multidisciplinary team. So really, the priority is what each of the people on this call is decided is the priority, and we will facilitate them to make improvements against those areas.
Thanks, Sarah Jane. And I've had the pleasure of seeing the wide range of representation of UEC champions. There's over 750 of them in total. So I'm going to pick one from that says, are there plans to ensure that primary care are fully invested and integrated in the delivery plan, particularly the right access point?
Yeah, so primary care, it's a great question. Primary care have obviously got their own recovery plan as well, and they're working through their implementation at the same time. A huge part of that is around access, as we know. But I think where we really interface with the primary and the UEC recovery plan is how those 111 services really work, what we can do around primary care surge and respiratory illness as we go into winter, how we can help and support by getting people to the right sort of care to support them, so that primary care can see, you know, the patients that have got more complexity that really need to be seen by a GP, and hospitals can be left available for those that need the unique set of services that are in a hospital. So there is the primary care only actions, but I agree with whoever's put the comment in the chat. It is about where this overlaps, and we are working very closely as, you know, two teams to get in the best place we can for this winter, but also to think about where next, because I think some of the approaches to recovery have given us some confidence that we can bite off some more transformation. So we're also doing some work, for example, of what the future of 111 might look like beyond this winter, next, you know, what do we really want from some of these services moving forwards.
Thanks, Sarah Jane. I think I'll pause there, but it's nice to see the questions flowing in, and as I mentioned, we'll be sharing the Q&A to everyone in due course, and if we've got time at the end of the session, we might double back to either yourself if you're still with us, or Julian. But I'd like to take this opportunity now to introduce Charlotte Aston, who is the Director of UEC Transformation Operations, who's going to talk about the expectations of being a UEC champion.
Thanks very much, Matt. So yeah, welcome everybody. Just want to say how excited I actually am to be here. If you hear the number 751, you'll hear it 10 times today, but I think it's absolutely amazing for us to have so many of you signed up to this programme, and so many of you actually live on the call with us as well. So I'm really, really pleased to be here. We're sort of moving into the second half of the session today, where we're going to get a bit more into the nitty-gritty of what the Universal Support Offer actually is. More importantly, what you've all signed up to in terms of being an IUEC champion with us, and a little bit, and Sarah Jane touched on it, what you can expect from us. This is a two-way process, and I'm going to use the word we a lot throughout my section, because we absolutely see this as a big team, us from national, regional colleagues right the way through to the systems, out into our providers, doing the best things that we possibly can for patients. And really importantly, keep the chat coming, because this is the first step in a 2-year-long journey of getting lots of dialogue between all of us in terms of how we move things forward. So next slide, please, Joe. So a little bit like Sarah Jane, I'm over 20 years experience in the NHS as well. I'm going to call it at 20 years. I don't think I want to age any further than that. But I think absolutely all of us recognise we all come to work to deliver the best possible care for our patients. And the way we do that is from developing, valuing and empowering our teams and our colleagues. And I just really wanted to touch on that because every day we come to work to do the best we can and deliver the best care we can. And I recognise when I'm out on sites, and I've worked in acutes myself, that at times it can be really frustrating at the moment. We are delivering care in compromised situations. A lot of staff are working against real big challenges. And I just really wanted to set the scene on this slide about that, because I think it's really important that we acknowledge we're not working in the easiest of environments and it is challenged. So I don't want to harp on about performance, but there's some real things here for our patients. So at the moment, in Q1 of this year, 2 out of every 10 of our patients over the age of 80 that went in through ED spent over 12 hours in that department. If that was one of our parents or one of our grandparents, we just wouldn't want to see that. And I know none of us on this call want to see that. Last week alone, we had over 11,000 patients in acute beds that didn't need to be there. We know the issues that creates for those individual patients, but also more importantly, the patients also trying to access care. And I think the absolute key thing against this challenging landscape is that we all recognise and we all want to change. So as a national team, we've been working really hard with our regional colleagues and also some of our system colleagues to really look at what is the opportunity that we've got going forward. And that is where the universal offer has really been born from. It's about creating a really passionate network of people from right across the spectrum that really want to drive and improve change across urgent and emergency care for our patients and their families. So I'm going to touch on it again. There's 750 of us signed up. We'll keep going. And it's in there, it's in bold. This is a huge opportunity for us to do something really, really different. And like Sarah Jane said before, improvement does work. We've just got to get it right. So I think one of the key things is to point out some of the differences that the universal offer brings compared to perhaps some of the things that we tried in the past. I think size and scope is one of them. As Matt said, every ICS has now signed up in terms of delivering their maturity indices and the work they want to do. And we've got champion representation from all of the systems as well, which is truly fabulous. Another big part of this is that we really want to support you in your improvement training and development. And I think we really recognise over COVID some of the access to training, etc., just wasn't there in the same way that it had been. So Helen Bennett from ESIS is going to talk to you when I shut up and go into a lot of detail about the provision of the training support that we're going to offer, but we thought that was really, really important. I think another bit, and it picks up some of the chat, and people are asking about best practice. We do have some fabulous examples of best practice and we will be sharing those along this journey, but also this is about developing more best practice. So all of you hopefully will have best practice examples at the end of this journey that you can use and that we can share nationally to help take this journey forward. And another thing that I think is really important to mention, it is a 2-year journey. It runs the whole length of time that the UEC recovery plan does. And that's in absolute recognition that in order to deliver real change, we have to give it time to evolve and embed. I sit on so many calls with so many people frustrated where we trialed small initiatives, and I've seen some bits in the chat about that as well. But what we don't do is ever give it the time to really evolve and embed. So that is a big part of this programme in terms of making it work. Have the next slide, please, Joe. So the universal support offer itself, I feel like I'm living and breathing this, so I will do my best to explain it, is 4 key components. I'm not going to talk about component 2, Helen's going to do that, but I'm going to briefly take you through 1, 3 and 4. We will next week provide some detailed information out via email to you all. We didn't want to do that ahead of this session, just really because it could be misread or misunderstood. We wanted to put the highlights out first and then we'll get the detail out to you. But the first part of the programme is around the self-assessment and evaluation. So all of your systems, and hopefully you are cited on this, but if not, through your IUEC system lead. So there's one of you in every system that is our lead point of contact. We will make sure that you see the maturity scores that were submitted for your system. And this was basically a review across the 10 areas listed in number 3, so same day emergency care down, about how mature you are. It was a 1 out of 8 score. 8 would be fabulous, fantastic, benchmarkable, wonderful, and down to 1 that you're on the start of your journey. And each of your systems has chosen roughly 4 areas where they want to focus their improvement offer. The other big part of this component, and this is really important, and I'm going to bang on about this so much for those of you that are on this whole journey for the next 2 years, you'll be fed up for hearing me, is evaluation. So we shouldn't be doing any improvement without measuring that we are delivering the improvement we want, and the same stands for this offer. We will consistently want to evaluate with you that both the training and support we're giving you, the tools that we're giving you, the access is working and is doing the right thing, and we would ask you to be really open and honest in terms of developing that with us. And also really importantly, that we actually evaluate the improvement that we're doing. So we will support you on your journeys to look at both the measures you're trying to change, but also any balance metrics to make sure we're not having any unintended consequences, but also understand why if things aren't working, and then we can look at that nationally and support you with, you know, policy redirection, etc., whatever needs to happen to make this work for our patients. So that's section 1. I'm going to skip over 2 and jump over to 3. So number 3 is actually delivering the UEC improvement, and I note some of the time commitment has been dropped in the chat, and this is probably where some of the greatest time element will come in. Some of you may have been involved in the Winter Collaborative. This is a similar offer to that. So week commencing the 18th of September, a selection of you will be invited, dependent on appropriateness, to join the modules that your system have chosen. So we will be running modules across all 10 of those areas, which very nicely line up to the winter plan. Essentially, weeks 1 to 4, we will ask you to join us roughly 2 hours each week, and we will take you on an improvement journey in terms of learning what best practice looks like, what national policy is, who's doing what well, also importantly, who's tried what and it didn't work, because what we don't want is lots of people making the same pitfalls. And we will help you design what you want to change and improve in your service. You'll have access to subject matter experts, clinicians, also improvers, and more importantly from your peers. And one of the big things about this is learning from one another and supporting one another on the programme. You will then fall into a round of action learning sets, which will be approximately 6 to 8 hours in total over the following weeks, where you will support one another with your improvement journeys, and we will join the calls to also help you. And then the final 2 weeks, which we've roughly allocated about 4 hours of sort of contact time, is around the evaluation part of the journey, where we will look at what did you try and achieve, did you achieve it, what worked, what didn't work, what can we take forward to support others, and importantly what your next steps are. As I said before, this is a long-term programme. These 4 weeks won't sit in isolation, so that's essentially the biggest time element. But I'm going to caveat that they're the taught sections. What's also important, and it's the day job for most of us, is that the improvement work is obviously delivered in between the sessions. That's the bit that's going to make the difference to our patients, their families, and really count for all of us. And importantly as well, and Julian picked up on this, for our staff, it's a really great opportunity to engage right across our stakeholders and our colleagues to get this work off the ground. Then the final component of the actual offer itself is number 4, which is what we're calling our Learning Lab on NHS Impact. Now, NHS Impact might be a new term to many of you on this call. It was certainly a new term to me not so long ago. It's the improvement transformation arm of NHSE, but importantly, they're going to provide us with a central online repository where we can store this session, for example, the taster sessions, and all of the good practice, rapid improvement guides and support tools that you will need to help you on your UEC journey. And eSIST are also going to build us some great support forums on there, so you'll be able to go into chat boxes, get support and help, and link with colleagues from right across as well. So Jo, can move on to the next slide, please. So essentially that is the universal offer, key to yourselves, and what we're really excited about, and the real reason really for having the UEC champions is about creating what we're calling this community of improvers. We really want to put improvement in the hands of the many, make people feel safe and trusted in what they're doing when they're trying to take forward this improvement and change, and that is exactly what this programme is all about. It's about upskilling, supporting and being safe. And we did some work across NHSE and ESIST, and we will share these links with you. A couple of the colleagues are on the call that helped develop this work, looking at some of our top performing organisations and systems. And we know that those organisations absolutely have the cultures and the leadership and the shared purpose and vision that really allows change to happen. So by spreading that across the whole of the country and working with yourselves, we really are hoping to create that community that will change things on the front line. Next slide, please, Jo. So you're probably still sitting there slightly scratching your head. So who are our UEC champions? And it's a shame because we're doing this virtually, you can't all see each other, but I promise you, you are an absolute diverse cross-section of some of the most passionate, ambitious people in the NHS. I know some of you, I don't know all of you, but hopefully we'll get to meet many of you over the next 2 years. But essentially you come with different and varying levels of experience, different professional backgrounds. This is about really working across management, clinicians, and when I say clinicians, I don't just mean doctors, AHPs, pharmacies, porters. We want everybody involved in this programme so that we can really deliver this together. We absolutely celebrate the diverse range of people that have joined, and we really hope that that will be representative of the patients that we're trying to change care for. Might need to think about getting some over 80 patient reps to support us, because they've definitely got part of this journey to be on with us. But as I said, the most important characteristic, and I hope you're all sat in there nodding along with me, is that you are enthusiastic, passionate, and really committed to making this improvement work. Next slide, please, Jo. So what does that actually all mean? So you know you're committed, you know you're passionate, but what do we want from you? Well, we really want to work with you and ask for your commitment in building your improvement capacity. And I won't take Helen's thunder, but she'll talk about that to you more in a second. We also want you to be day-to-day advocates and role models for promoting our UEC improvement right across everybody that you work with, every meeting that you go to, really ironing out the issues and helping to move that forward. We want your participation in the appropriate improvement modules, and Sarah Jane touched on it. We know we've got a lot of challenges, industrial action, we're heading into winter, but they are relatively short periods of time, albeit I accept against a very busy background. But please, if you're involved in the modules, do come along, because it's the only way we'll get that to work and we'll be able to support you. My favourite word, evaluation. Please participate in the evaluation and really help us to shape this programme as we move it forward. But for me, this is kind of the crux of it, really. We want your support to create a nationwide movement that will deliver the care our patients deserve and the environments our staff want to work in. And I would love to think in a couple of years' time we could go out on visits to sites and actually see those things really being delivered, but being consistently delivered everywhere. That's a really big part of the role of being an IUEC champion. Next slide, please, Jo. So what do you get back from us? So we're asking quite a lot here, and I think we recognise that, but we are really hoping you see this in a really supportive way. And I think critical to this is understanding the support that we will give you. So I've chatted a little bit already, but we absolutely will create the channels of engagement. We will make sure that you understand and see what best practice looks like, that you have access to the most upcoming policy, subject matter experts, improvers, just coaches and general support throughout the programme, and we will listen to you. And I think that is so important. So if there are things that this isn't delivering that you need it to, we will take that on board and we will work with you to change that. I'm going to stop there because I don't want to run us out of time. I think we've got a little section for questions, but I do just want to say a massive thank you. I'm really looking forward to going on this journey with you. And I think more than ever, our patients really do need us to land this one in its fullest. So thank you for your time. Matt, back to you.
Thanks, Charlotte. Not quite back to me in the sense that I'm going to ask you a question, but just mindful of time, I'll only spare you one for the moment, and it's quite a relevant one. Clearly, most of the work will happen at a system level, and they will need to be led by the system with support. Do you have any advice on the level of support that recovery champions in one system should or could look like?
So at system level, it's quite variable because of the variation in size of system, in all honesty. So that was something I learned when I moved to the national office. We've got some really huge systems and some really small systems. So some with multiple big acute providers, some with others. But each of your system does have an IUEC system lead, and we will work with them to make sure you get the support you need. And also a sign up went out from the letter originally went to your AO at system level that you will be given the support support and time by your system to deliver this work. So we will work with you on what that looks like, but absolutely there was a commitment both from us as a national office, but also from your system that would be put in place to enable delivery of the offer. Does that answer the question?
Thanks, Charlotte. And as promised, we will get a full Q&A of all these answers because some really good questions in there for everyone. But save the best till last and all that. Sorry, Julian. I'd like to now introduce Helen Bennett, who's the head of eSystem. I'm sure many of you will know her from the work out in trusts and systems. So over to you, Helen, to talk about the building capacity module.
Lovely. Thank you, Matt. And good afternoon, everyone. I'm really happy to be here with you and just follow on from the speakers this afternoon. So I'm just going to talk you through what the building improvement capacity module is and what it's about, and also just to give you a little bit of insight into what to expect over the next 4 weeks for this. But just before I do that, just to really reiterate some of the words that both Sarah Jane, Julian and Charlotte have just said around improvement, and just to try and give you the confidence. Some of you will be really old hats at improvement, and you'll know, and you'll have been on your own improvement journeys previously and know quite a lot of the skills that are really helpful from a practical sense. Others of you might not, and it might just be completely new, and you might be sitting there thinking, oh my goodness, I'm not really sure how I'm going to do this, or if I even know how to do this. So this module really is based on refreshing those skills that you may already have. And for those of you that are new to this, it will give you some of those core skills and help to build your confidence whilst we're starting on this improvement journey over the next 2 years. And really, for those of you that are perhaps wondering whether or not you've sort of signed up for this, and you may be wondering whether you can do this, improvement isn't scary. It doesn't have to be huge. It can be, and it can come with a lot of documents that Sarah Jane talked about earlier. But it can also be some of those really small things that you know are going to make a big impact for your patients that are right in front of you. And some of the innovation and the best conversations will come from a couple of you as you're joining forces and you're getting to know each other with your networks. And those corridor conversations, as we used to call them, where you just are really inspired by something that you know a colleague or a new friend is doing and you want to just give it a try. So building the improvement capacity offers you that safety in which to do that. So it's designed to equip you with the tools and knowledge to establish some of your improvement plans, what that looks like, what they could look like, and to give you some of the improvement methodology and science, maybe for the first time, but for those of you that are not new to improvement, just to refresh some of your skills. We've put 4 components into each of the learning events, and they'll come through and help you really deliver the essentials that we're talking through now. If we go to the next slide, please, Jo. So just to give you a brief timeline, we start, obviously, you've got the session today. We then go into our taster sessions over the next few days, and they will cover off items around partnership working, how to use data for improvement, and the principles of high functioning organisations. And colleagues that are on the call already will take you through what each of those sessions looks like, and then that'll get you ready as we start into the core learning event, which starts for you next week. So really preparing your improvement journey. We also, running alongside this, will give you some of the tools, as Charlotte's just described on NHS Impact, to supplement your learning as you're going through. So there'll be offers and availability of resources for you to look through to really help guide some of that. If we can go to the next slide, please, Jo. So the core learning, what is this, what we're going to do? So preparing for your improvement journey will help you create the right environment, understand what your first steps are, how to set things up, how to get things moving, and how to access things in the early phases. We then go into leadership and the delivery of your improvement plan. So what are the principles of effective leadership, and why are these so important when you're talking about improvement, and how you can influence change in your environment? And I'm delighted to know that there's a wide spectrum of people joining us in this journey, and for me it's really important that front-facing patient team members have opportunity to really get into improvement in whatever stage you feel is appropriate in your environment. We then go into the next section for turning data into intelligence. And this is actually more exciting than some of you might think it is, where you can really see what you're measuring and what the impact is having and how you can display that and show and share it with colleagues, not only in your environment, but also across the networks that you'll be developing along the way. And we then finish with the tools and techniques to support all of this. So we will help you and equip you with some of the tools that you'll need in order to support and evaluate your improvement work. Some of these will be really practical things, and some of those will perhaps will take a little bit more just talking through as you go through, but based very much in the practical space for you. If we go to the next slide, please, Joe. So just as we're going through, obviously this is quite a small whistle stop. We are here to continue supporting you as we go through these. The taster sessions really are an opportunity to just dip your toes in before we start next week with the actual core components. So we really do encourage you to join tomorrow. The links are on the pack. You will have all been sent these already, to really have a look at what partnership working looks like. And then on Monday, we have the opportunity to talk data and measurement for improvement, really understand what it looks like and how you can best utilise what you have. And then we go into Wednesday when we are talking principles of high functioning organisations, which is where some of you have just asked around where best practice is. What does that look like? We have the privilege of working alongside a lot of systems and organisations, and I would say everywhere we go there will be good practice, and it's about how you can share that together, learn together and network, and take some of the ideas that others are using and adapt it so that you can put it into your environment and make it useful and patient focused for you. Okay, so that is very small whistle stop, which is helpful so that we've got a little bit more time now to go back to Matt, so you can do some questions then, Matt. Thank you.
Thanks very much, Helen. And the chat has certainly been booming while you've been talking away. I think I've probably got a question that I can pick out with the time we've got left for all of you, Helen. And there certainly was one for you, so I'll start with you if that's okay. Need to pick it up. So the person's put, I work for an ICB where ISIST already have developed an action improvement plan for the acute trust. Do they still have a role here as an IUEC champion? What advice would you give them?
Sorry, just I missed that first bit. You work in an ICB that they've already got an improvement plan. Is that the question?
They've already got an improvement plan developed in conjunction with ESIST. Do they still have a role here as an IUEC champion?
Absolutely, absolutely. And how we can work with you, if you're already working with us, that's brilliant. So you know us and you know how we work, and I'd hope that you would recognise that it's very practical and hands-on. So really, absolutely, we can look through your plans with you, see where you are, reevaluate what's gone well for you, and perhaps where else we might need to focus. But really welcome those conversations. So absolutely, yes.
Thanks, Helen. Charlotte, put you in a challenging position here, if that's okay. So there's a couple of comments in the chat around time commitments and understanding that, and obviously we've given a whistle stop tour and some of it may appear a little bit vague in what we're asking. So how are we going to address that and give people more information as this develops?
Yeah, no, thank you. And I do appreciate the time commitment. As with implementing any change appropriately and well, there is always going to be a time element to that. So as Helen said, the initial improving capacity, building up your improvement knowledge, dip in and out of that as is appropriate to you. If you've already got a level of knowledge, you don't need to do that. But we are really hoping people see this as a positive opportunity to develop themselves in that area. The actual modules have evolved. I think we did put some time sort of in terms of people knew they would be doing modules in the ask, but it's 14 weeks. So it is quite a long programme and only 18 hours of sort of contact time over that 14-week period. So when you break that down, it's not actually that great. We're also not expecting every single champion to be on all of those initial modules. So I'm just going to use an example. If you're working in SDEC, for example, there might be 3 or 4 of you that are supporting the improvement piece, or even more, but you may choose to only send one individual to the actual collaborative session so that they can get the learning feedback, etc. So we will be as flexible with you as possible. But I think we all recognise that in order to deliver an improvement journey, that there is going to be a time commitment that we are going to have to make. We've also worked with your systems and via the regions that for some maybe more challenge systems, or some systems where you've already got some quite weighty pieces of improvement, then you've not signed up to quite as many modules as some of the systems that perhaps don't have other things happening. So again, that sort of check and chase bit has been done through your regions and your system leads. But we'll get back to you with the information on what you signed up to, and that will help give you a better idea of time commitment for your individual areas. I think the other thing to say, some of you have signed up sort of 40, 50 champions in one system. It may be in those initial modules only a quarter of you are actually involved, so the time commitment isn't per individual, it is across the system. Thank you.
Brilliant, thank you, Charlotte. And we'll be using the UEC Champions email address to share more information with you all. So, do keep an eye out for that. And I've just seen in the chat there's some questions around making sure that we resend the links to all the sessions and we share the recording of the video. So, given that has taken us a minute over time and everyone is very pressured, I am going to wrap us to a close there and just say an enormous thank you, firstly to all of you, nearly 300 of you that have joined and dialed in today, and all of those that will be watching this on playback, but also to Helen, Charlotte, Julian and Sarah Jane for their time today. Hopefully you found it interesting, and hopefully we'll be able to meet your expectations. And on that meeting expectations, it would be amiss of me not to just say that we'll be sharing in the chat box a feedback link. So please do give us that feedback, because we want to tailor this improvement offer to what you all need at a system level, and the only way we'll know how to do that is without looking at all the questions that you've given us in the chat today. So I'm going to end it there, but say thank you very much, and we all thank you for your hard work and commitment to improving integrated and emergency care services. Thank you.